Hi, my name is Moise, and I'm one of the internal medicine residents at Spera Hospital, Michigan State University. I'm going to be presenting a rare case of reverse Takotsubo cardiomyopathy after seizure. Takotsubo cardiomyopathy is a rare form of non-ischemic cardiomyopathy that is characterized by transient regional systolic dysfunction of the left ventricle. Several variants of Takotsubo cardiomyopathy have been described based on the regions of the ventricular wall motion abnormality. It can be classified as classic, reverse, mid-ventricular, and localized. Here we present a case of a patient who presented with reverse Takotsubo cardiomyopathy following an episode of seizure. Our patient is a 37-year-old female with a past medical history of hypertension, schizoaffective disorder, and alcohol use disorder. She presented to the emergency department after 2 episodes of witnessed generalized tonic-clonic seizures. Her workup was significant for elevated troponins as well as an acute kidney injury. Blood alcohol level and urine drug screen were negative. Her EKG revealed sinus tachycardia without ischemic changes. An echocardiogram was also obtained that revealed new onset cardiomyopathy with a reduced ejection fraction of 30 to 35%. It also showed an unusual wall motion abnormality, which was described as preserved apical segment motion with akinetic basal segments. As you can see in the first video, the basal segment seems to be akinetic, while the apex is contracting. Left heart catheterization was performed after this, and it revealed normal coronaries. The patient's clinical status improved, and she was started on guideline-directed medical therapy for heart failure. Follow-up echocardiogram in 6 weeks showed recovered ejection fraction with complete resolution of wall motion abnormalities, as can be seen in the second video. Reverse Takotsubo cardiomyopathy is characterized by basal akinesis or hypokinesis associated with apical hyperkinesis, without an evidence of obstructive coronary artery disease. It has been more frequently reported in the younger population, particularly women, and in association with distinctive stressors including eating disorders, amphetamine use, and seizures. The pattern of ventricular involvement appears to be related to adrenoreceptor density in the myocardium. Younger patients express such receptors more intensely at the base of the heart compared to the apex in older patients. More importantly, reverse Takotsubo cardiomyopathy has significantly higher elevations in cardiac enzymes compared to the classic subtype. Reverse Takotsubo is also more often associated with a neurological disorder than the classic subtype. Despite low prevalence of Takotsubo cardiomyopathy in the general population, with an estimate being around 1.2 to 2.2%, the practical prevalence of transient regional wall abnormalities seems to be greater than what is reported. This is due to limitations in fulfilling the proposed diagnostic criteria. Some of the limitations described in literature include younger age of patients, making the presence of significant coronary artery disease less likely. Supportive therapy is the typical approach for managing stress cardiomyopathy. Nevertheless, patients facing complications like heart failure are usually treated based on standard guideline used for heart failure management. The in-hospital mortality rate stands around 3 to 4%. For those who survive the acute episode, it's common to observe recovery of systolic left ventricular function within a period of 1 to 4 weeks. The likelihood of recurrence is estimated to be approximately 1 to 2% per year. The proposed mechanism underlying stress-induced cardiomyopathy remains to be an exaggerated sympathetic response, whether triggered by an emotional or a physical stressor. Seizure-related Takotsubo has been an increasingly recognized entity in the cardiovascular field, with the reverse subtype being a particularly rare occurrence. Although a transient process, morbidity and mortality related to this condition remain concerning, which is why it should always be included in our differentials and appropriately investigated. Thank you.